This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2018, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is the use of non-invasive ventilation at the end of life. Dr. Shawna Strickland is a registered respiratory therapist, asthma educator, and fellow of the AARC. She is the Associate Executive Director, Member Services for the AARC. Dr. Strickland discloses that she is an adjunct faculty member at Rush University and a Center for Health Ethics Scholar in the University of Missouri School of Medicine.
Thank you very much for joining me for this presentation. The whole focus of today's presentation is to talk about non-invasive ventilation at a point in time where the patient might not be bridging to recovery. So what I really want to focus on in this session is a discussion about, number one, what is non-invasive ventilation? How does that relate to our patient? What's the patient experience? And then we'll talk about the pros and cons of using non-invasive ventilation at the end of life. So as we move along through this presentation, we'll talk about some basic concepts of non-invasive ventilation, and we'll talk about some basic concepts of ethical principles so that we can then apply these to case situations and identify the best ethical course of action for any given patient. So let's start off with a case study. This particular case was one of the first ethical challenges that I experienced in my career way back in the day. So our patient is a 15-year-old. Now, we'll call him Joseph. Joseph is a patient well known to our facility. He was born with an anoxic brain injury, and so as such has severe developmental delay and lots of other comorbidities that we've identified over the years. He's been in and out of our facility. We know his family very well. He does live in an assisted facility at this point, though mom and dad do retain the power of attorney and legal guardianship of Joseph. Due to their work schedules and such, they don't see him as often as they'd like. They're not as involved as much as they'd like to be, but they do have that legal guardianship of Joseph. At this point, Joseph presents to us with a fever, a high heart rate, high respiratory rate, and shortness of breath. His work of breathing is increased. He does have some cyanosis, and he has been diagnosed with acute respiratory failure secondary to pneumonia. Now, the other issue here with Joseph is that he does have kidney disease, so his kidney function is almost non-existent. Now, this is independent of his pneumonia diagnosis. So we have two issues. We have an acute process that has recently developed and is causing the signs and symptoms we're currently facing, and we have this chronic kidney illness that has unfortunately progressed to a point that cannot be reversed. Again, Joseph does live in that long-term care facility. Parents retain legal guardianship. Now, the parents did write an advance directive for Joseph a couple of years ago when it appeared that his chronic kidney illness could not be reversed. So we need to keep that into consideration as we progress with our case. So let's go back to that acute respiratory failure for Joseph. So he's been diagnosed with pneumonia, and the physician recommends that Joseph be placed on non-invasive ventilation for this acute respiratory failure issue. The respiratory therapist is a little concerned because Joseph's parents have written a DNI, a do not intubate order. The respiratory therapist is concerned that perhaps we're cheating by providing non-invasive ventilation. Technically, we're not violating that DNI order because we're not putting in that breathing tube. But with our level of non-invasive ventilation technology, we can set an inspiratory pressure, an expiratory pressure, an inspiratory time, a respiratory rate, we can add supplemental oxygen. So we can use the non-invasive ventilator like a mechanical ventilator, except we're not using the endotracheal tube. So the respiratory therapist is concerned that this perhaps might cross some ethical barrier. So here is the ethical concern. Should we be able to use non-invasive ventilation in this particular instance at the end of life? We know that Joseph's kidney function will not return. Even if we reverse this acute respiratory failure, we will not reverse the kidney disease. So, are we causing harm by providing this positive pressure ventilation intervention, or are we causing harm by not providing this intervention? Are we violating that do not intubate order? If Joseph had a do not attempt resuscitation order, would we be violating that order by utilizing this intervention? And then we have to think about the burdens and the benefits. What benefit will we have from the non-invasive ventilation versus the burden placed onto Joseph? So as we go through this particular scenario, we want to take a step back and talk about what the intervention actually means. So let's take a step back and talk about non-invasive ventilation as a technology. So we know that non-invasive ventilation is the application of positive pressure through a facial interface of some sort. So we can put nasal prongs or a nasal mask or a full face mask or a helmet, not popular here in the US, but something our colleagues abroad use. When I started in the profession and we were using non-invasive ventilation with the old BiPAP STD units, there was one mask, one size fits nobody, right? And it had the hard plastic shell with a hard plastic interface for the nares that went around the nares. So there was a lot of issue with leaks, with pressure sores, and trying to find a mask of the 3 or 4 sizes that were available at the time to try to fit our patients. And if we're talking about pediatric patients, especially those 10 to 15-year-old kids who don't really fit the pediatric model but don't really fit the adult model either, we had a really hard time finding a fit for those particular masks. Now we have lots of options for masks, things to make our patients more comfortable, things to take off pressure and relieve pressure areas so that we don't develop pressure sores and ulcers and such for our patients. Lots and lots of options out there, but ultimately we are applying positive pressure. We apply a positive expiratory pressure to stent open alveoli. We apply a positive inspiratory pressure to open up the lungs, to help the patient supplement their breath so that they can exchange gas appropriately. And as we said earlier, we can set a rate, an inspiratory time, add supplemental oxygen, and have all kinds of interventions with this particular modality without the hazard of placing an endotracheal or tracheostomy tube. So now that we've reviewed this non-invasive ventilation concept, let's switch gears for a moment and talk about ethics. There are a lot of different ethical theories that we use to evaluate these situations. One of the more popular theories that we use in evaluating medical ethics cases is the Principalism Approach, or what some call the Georgetown mantra. And there are 4 basic principles within this approach to evaluating ethical situations. The first is autonomy, and autonomy means that the individual can make a decision for him or herself. In the context of medical ethics, this means that the individual can make healthcare decisions for him or herself based on the information we provide. So sometimes our patients are able to make these decisions for themselves. We call that decisional capacity. They can take in the risks and benefits, they can understand what that means in the context of their condition, and they can make a decision about whether or not they want the offered intervention that we have provided. Some of our patients do not have decisional capacity, such as the case of Joseph. Joseph is a little compounded because not only is he under the age of 18, which is a legal age in the United States to have free decisional capacity over oneself, but also because he has a developmental delay. So even if he were over the age of 18, he would not be able to make those decisions for himself. Not only is he unable to comprehend cognitively what's going on in his situation, what we're offering, risks and benefits and so forth, but he's also unable to communicate with us. So he's unable to tell us what he would like. In those situations, we have a surrogate. So within that surrogacy, we have a mom, a dad who are involved. They retain their guardianship, legal guardianship of Joseph, and they can make those decisions for him, hopefully in the best interest of Joseph. And this is where it gets tricky with adults. If an adult has had decisional capacity and goes into a facility and for some reason loses decisional capacity, maybe they are sedated or they're going into surgery or some other reason that they wouldn't be able to communicate with us about their needs and their values, someone else will have to make that decision for them. So usually that's the next of kin, mother, father, sibling, spouse, adult child, who can help make those decisions. In the case that the patient does not have a surrogate decision maker, then the state can step in and assign that person a guardian ad litem who can help make those medical decisions for that period of time. But back on the track of autonomy, the ethical principle is that the human who can do so should be able to make his or her own decision about what care he or she really wants to receive. The second principle is justice, which is a fairness principle. Am I providing the same level of care and options to everyone in that situation? So perhaps the level of care offered toward Joseph is not in line with what we would have offered a child who had a non-terminal prognosis. Are we providing the same level of care to Joseph, even with his comorbidities and his developmental delay and his age, that we would offer to any other patient who came in with an acute respiratory failure brought on by the pneumonia? So the justice principle is very applicable when we're evaluating these kinds of ethical dilemmas. We also have the concepts of beneficence and non-maleficence, and these are not opposites. So the concept of beneficence is to do good, to do an active good. Are we actively promoting a positive outcome for this patient? The concept of non-maleficence is to avoid harm. So is what I'm doing avoiding a harm for that patient? Now we have a little gray area here with omission. I can do an activity or I can refrain from an intervention and not cause harm, but is that intervention doing any good? A common example of this is giving an albuterol nebulizer. Many of us say, oh, it's just albuterol, it's not that big of a deal, we do it all the time, there are very few side effects. But if it's not causing a positive good, does that mean that it's still ethical to administer, even though we're not actively causing a harm? So the issue with using these principles, these four principles, autonomy, justice, beneficence, and non-maleficence, to evaluate an ethical situation is that we don't know what the level of priority is. Which one gets top billing? At what point does one principle take precedence over another principle? Is beneficence always the top principle? When in doubt, always choose to do a positive good? Well, that depends. What's your definition of good? Is your definition of good the same definition of good that the patient might have? So in our definition of good as respiratory therapists, typically, we err on the side of life, prolonging life. Do what we can to make sure that the patient continues to live. But depending on the patient's lived experience, where they are with their disease process and where their prognosis might lie, there's the potential that good, as defined by the patient, does not mean prolonging life. Perhaps good for the patient means a quiet, comfortable death versus extended period of time with a chronic disease process that could be potentially painful and harmful to their social network, their psychological state, and their emotional state. So this is where having conversations with the patient is always very, very important. Having those conversations with the patient's family, the patient, the entire care team, to understand where their priorities and their values and their belief systems align so that we can help them make decisions that are appropriate for them. We could also look at autonomy. It's very interesting to me that we only question a patient's decisional capacity when they disagree with us. If we propose an intervention and the patient says, why, yes, I would like that intervention, we don't question whether or not they're capable of making that decision. But when we offer an intervention and the patient says, no, thank you, I would prefer not to have that, then we say, is this patient really able to make a decision for him or herself in a logical fashion? But as an aside, we also have that autonomy piece. Does autonomy always win? Do we always give the patient what he or she needs? So that's the difficult part with using these principles to analyze ethical situations. Should we always choose autonomy and give the patient everything he or she wants? Is that ethical to others to use that resource in a situation that may not benefit the patient, even though the patient wants that intervention? So this is the challenging situation we find ourselves in when we're trying to evaluate an ethical problem and find that solution to produce the desired outcome. We also have to account for our own biases. So let's take a look at the respiratory therapist for a minute. So here we have a practitioner who is very experienced with this kind of intervention. Lots of patients coming through our door. Clinically, we're very, very good. We have a lived experience that we draw upon every time a new patient needs this intervention. And so when we're applying this intervention toward our new patient, Joseph in this situation, we have a bias. We think of the patient similar to Joseph's case where we used non-invasive and it either worked or it did not work. Or maybe there was a negative outcome with a family member. These are things that bias the way we look at the situation. Perhaps the respiratory therapist in Joseph's situation is recalling a time where he or she applied non-invasive ventilation to a patient in similar situation, and there was a negative outcome to that. Either the family was upset or the patient was uncomfortable or someone else questioned the level of ethics utilized to provide that particular point of care. So we draw upon these past experiences with every new experience that we have in the hospital. So we have a practitioner bias against or for the situation based on our past experiences. But not just with similar patients, also with our physician colleagues. So perhaps the physician in this case has had some conflict with the respiratory therapist, or the respiratory therapist knows that the physician in this case has a reputation for ordering questionable interventions. And that's also making the respiratory therapist think twice about whether or not this is an appropriate intervention for Joseph. So it's important for us as respiratory therapists to not try to be completely neutral in this situation, because I don't think that that's possible, but rather recognize the biases we have, frame them, acknowledge them, and then try to look at the situation understanding, yes, I have a bias either for or against this physician. Yes, I have a bias for or against this patient situation. Before we move too far into evaluating the ethical piece, I want to make sure that we're all on the same page with various definitions. So our first definition in this case is the DNI, do not intubate. That literally means do not place an endotracheal tube in the patient's airway. It doesn't say anything about oxygen, suctioning, mechanical ventilation, cardiac meds, nothing else. It is the literal placement of the endotracheal tube. We rarely see the DNI order independent of anything else. Usually when patients make this kind of a determination, it is within context of the other interventions that might be given at that point in time. Remember that the DNI is an order written by the physician, right? This is not something that our patient can go to a lawyer, draft up a document and say, here you go, here's my DNI. So the physician works with the patient and family, when appropriate, to make the decision as to whether or not they should be able to place an endotracheal tube should the patient go into respiratory failure. So the do not resuscitate terminology was changed to do not attempt resuscitation, because when we used DNR, the family assumed if we attempted the resuscitation process, we would be successful. So when a physician would approach a family about signing a DNR order, a lot of families were hesitant because they felt that signing that order meant they were taking away a positive intervention for their family member. And so the thought was, well, of course I don't want my family member to die. And if I sign this order, then I am in effect killing my family member, which of course is not the truth. But that was the implication of that wording. So when we changed it to do not attempt resuscitation, we're trying to be more explicit with the terminology and say, we can try, but that doesn't mean we'll be successful. Do you want us to even try chest compressions or manual ventilation or suctioning or cardiac medications or whatever intervention that might be? And it's interesting that we have to frame this in such a way and remind our family members that witnessed in hospital ventricular tachycardic arrest has a 17% chance of survival to discharge. So even in the best of situations, CPR is not always effective, and our patients need to understand those outcomes and limitations so that they can make that informed decision. Now, the living will is a different kind of document. This document is not a physician order. It is written by the patient at a point in time where he or she had decisional capacity. Now, it can be written with a lawyer, and probably a good idea to do so, but it doesn't have to be. There are lots of templates out on the internet that people can pull down, sign a document, this is what I want, this is what I don't want, and put that in their medical chart. So again, written at a point in time where I have decisional capacity, but I'm anticipating a time in the future when I might not. So perhaps I write a living will that says, in the event I have a stroke, I do not want life-saving attempts. Do not perform CPR, do not intubate me, or I could give a list of things. Now there's an issue with this living will. It is a snapshot in time. So if I write it today, in 10 years from now, I can't predict what kind of technology medicine might have at that time. Maybe in the next 5 years we find this miracle drug or intervention or something that when a patient has a stroke, we perform this intervention, the stroke effects are reversed and everything goes well. We don't have that today. So for me to make a decision today on what medical interventions are acceptable to me and not acceptable to me means that I might not be in the same frame of mind in 10, 20 years when that actual situation occurs. The other issue with the living will is that sometimes it's not very clear to interpretation. When the person writes it, it makes absolute sense to them. They know exactly what they mean, they understand the context, but when we're reading and interpreting that living will, that person is not communicative, right? Otherwise, we would just ask the patient instead of reading the living will. So within that living will, at a time that we are reading it and trying to interpret it, we have to read the meaning behind what that patient really wanted. What does he mean? No cardiac medications, none? So is that emergency medications or maintenance medications? So the vague nature of this living will can be an issue as well. Now, power of attorney can be a little more flexible, but again, this is also not a physician's order. This is when the patient works with a family member or a trusted friend to make those medical decisions for him or herself after they lose that decisional capacity. So we're not ironing out exactly what interventions are acceptable to us. We're empowering another individual to do so. Before I was married, my mother and I had a very frank conversation about what was acceptable to me and what was not acceptable to me. Unfortunately, at the time, we didn't really see eye to eye. I had a lot of medical experience in the critical care area. I saw how some of the patients had to suffer a bit before they either got better or they passed away. My mother is not in the medical profession. She did not have that lived experience, and we didn't see eye to eye on interventions. So it was a trusted friend that I had worked with to make sure that should I be in a situation where I lose decisional capacity, she could help make sure that I had the interventions that were aligned with my own values and belief systems. Now, of course, I'm married, so I don't have an official surrogate, but my husband is my next of kin, and having these conversations with that person who will be making those decisions is very important to making sure that we follow what that patient wants for the future. So now that we have looked at the basics of non-invasive ventilation, we've looked at interpreting ethical situations based on principalism, and we've reviewed some key terms, let's go back to the scenario and the problem. What is the root of the problem our respiratory therapist is facing in this situation? Quite frankly, is it ethically appropriate to use a non-invasive form of mechanical ventilation to an end-of-life patient with a DNAR or DNI? And subsequently, does DNI mean the same as no mechanical ventilation? So let's take a look at the literature. There are many arguments both for and against the use of non-invasive ventilation in this situation. Let's start with the arguments in support of non-invasive ventilation for patients at the end of life. The first point is that the non-invasive ventilation alleviates respiratory distress. So our patient is uncomfortable. They are short of breath. That might produce some anxiety. Obviously, the patient would be working hard to breathe, using lots of accessory muscles and such. Non-invasive ventilation can reduce that work of breathing, can reduce the amount of energy expended by the patient, and make that patient more comfortable in that moment. Even if we don't expect that the non-invasive ventilation will reverse the outcome of this particular situation, just the process of relieving the shortness of breath does provide comfort for the patient. So it is a palliation maneuver to help the patient be more comfortable in that moment, even though we have that acute respiratory failure. It's great for reversible acute lung disease, right? The pneumonia is not a chronic disease. If we look at Joseph's situation, his chronic disease is his kidney disease. That has absolutely nothing to do with his pneumonia. We can reverse his acute respiratory failure due to the pneumonia, even though we can't impact the outcome of that kidney disease. Also, as opposed to mechanical ventilation with an endotracheal tube, we don't have to sedate the patient. So we can apply this non-invasive positive pressure ventilation without having to establish some sort of level of pain control, which also improves cognitive ability for those patients who do have decisional capacity. So we can keep them conscious. We don't have to provide them with a higher level of medication. Obviously, all medications come with some sort of side effect, so we don't have to worry about the side effects from sedation or over-sedation or under-sedation and trying to titrate to that effect. So we can use this in a way that's comfortable without a lot of other interventions to make it palatable to the patient. Again, we can improve comfort by easing the breathing. We can increase a little bit of our oxygen saturation perhaps, drive a little bit of that CO2 down, and make the patient overall more comfortable. So again, even for those folks who are very set on the non-invasive ventilation will not cure this patient, it does still provide some beneficial effects so that at least we can help the patient become more comfortable in the moment. For those patients with decisional capacity, we can provide a bit of time for them to finalize their affairs. So again, remembering that just because we're providing the non-invasive ventilation doesn't mean that the patient is not still terminal due to whatever issue is happening. So another case that comes to mind is a gentleman who was a stage 4 COPD patient, well known to our department. He was in his 60s. He and his wife were in the hospital, another exacerbation. This one was very, very severe, and the pulmonologist called, brought the ethics team together. We went and talked with the patient, and the pulmonologist had a wonderful, frank, respectful conversation with the patient and said, "This is the last exacerbation. I can't reverse you. Here are some options. I can provide you with this non-invasive ventilation. It will not reverse the exacerbation. It will not make it any better. We can put you on the mechanical ventilator, but we've already had the discussion that you don't want to die on a mechanical ventilator. And if we intubate you and sedate you to try to ventilate you, I feel confident that you will not come off of that ventilator and go back to your prior quality of life." And even though it was a harsh conversation to have with the patient, it was open, it was honest, it was in line with the relationship the physician and patient had already. And the patient opted for the non-invasive ventilation, not because he thought he was going to get better and go home, but because his daughter was in California. And that provided them time for the daughter to fly back to Missouri, spend time with her father. They could finalize their affairs before the father passed away. And again, even though it was a very difficult situation, it also allowed that family to have some closure and provided them to control the dying process on their terms versus at the will of when his body decided it was time to quit. However, there are a lot of arguments about why we should not be using non-invasive ventilation at the end of life. First, there is still the argument that this is a form of life support. Our first non-invasive ventilators were fairly basic, a little bit of EPAP, some gas. If you were creative, you could pipe in some extra oxygen in there. But as time has gone on, we've gotten some very, very sophisticated machinery. And that very, very sophisticated machinery means we can do a lot of things with it. And I've worked with many physicians and respiratory therapists who have said, I can make this non-invasive ventilator work like a ventilator. That's not necessarily a bad thing unless the patient has already identified, I don't want to die on the mechanical ventilator. I do not want to prolong my life on the mechanical ventilator. So we still have that argument that we might be cheating by simply using the invasive ventilator type intervention with a facial mask of some sort. Therefore, it's not invasive mechanical ventilation, but we're achieving the same outcome. Non-invasive ventilation is contraindicated in some conditions. Patients with active hemoptysis should not receive non-invasive ventilation. Some of our cystic fibrosis patients may not be able to tolerate that. So we have to be careful about saying it is always acceptable to use non-invasive ventilation at the end of life, because we do have to be very, very careful about what other interventions the patient might need and whether or not this non-invasive ventilator can provide the level of support that this patient needs without also providing more side effects and detrimental effects. Some are very critical of the fact that all we're doing is prolonging the dying process. And I hear this a lot from respiratory therapists in the field who say, I don't know why we're using non-invasive on Mr. Jones. He's dying anyway. We're just putting him through more painful procedures. We're keeping him alive longer. This is for the family, those kinds of things. And that's a hard thing to reconcile because we do see these patients day in and day out. It's hard to watch the patient suffer. It's hard to work with the care team to make sure that the mask fits appropriately, that it's not too tight, but it provides the right ventilation when you can see that the patient is uncomfortable or you can see that negative outcome. And are we violating the patient's desires? If the patient has already provided some sort of a written order identifying that I want to limit the level of life support that I can get, am I subverting their autonomy by providing this non-invasive ventilation, which could then prolong their life? So we have some issues here that we have to reconcile with ourselves. Am I doing this for the patient? Am I doing it for the family? Am I doing it for the care team? Many of us are worried that by trying to avoid a lawsuit, we do too many things to our patients. And this is one of those things that I've heard respiratory therapists worry about when we're talking about providing appropriate interventions to our patients based on the context of their disease process. We also have this concept of false hope. Our patients' family members are looking for some positive reinforcement that their patient, their family member is going to go home or get better, or that things are going to go back to normal and quality of life is going to come back. And unfortunately, we can't always give them that positive reinforcement. But when we walk into the patient's room, we tend to be as upbeat as possible. If our patient is doing poorly, the blood pressure is 40, and we are maxed out on all of the vasopressors, and maybe today the blood pressure is 43, we're all tempted to walk into the room and say, oh, look at that, the blood pressure's better. What does the family hear when we say that? The family hears, my loved one is getting better. What we mean is the blood pressure went up by 3 millimeters of mercury. So when we apply non-invasive ventilation to a patient at the end of life, we see immediate positive effects, right? We apply the mechanical ventilation, the non-invasive ventilation, the face mask, the nasal mask, whatever we're using. We see a drop in CO2. We see an increase in oxygen saturation. Maybe heart rate drops a little bit. Maybe the patient pinks up a little bit with the supplemental oxygen. Maybe the patient works a little less. They look a little more comfortable. All of those nonverbal cues make the patient's family feel like, oh, we're getting better. We're going to get through this. We're not going to have a negative outcome from this particular situation. When in reality, the patient would not be doing any better. And if we remove that non-invasive ventilation, the patient may die. So we have this concept of false hope. Just because I use a non-invasive ventilator doesn't mean I'm bridging to recovery, doesn't mean that I'm providing a positive outcome. Simply means I'm alleviating those temporary symptoms, and we may not be able to sustain that. So is it ethical to provide that false hope to our patients' families in that moment? And of course, the system itself causes discomfort. We don't see quite as many of these situations today that we did when we first started using non-invasive, but a very common problem in those early days was the breakdown from the pressure on the top of the nose. So very, very thin skin, not a lot of padding underneath the bridge of the nose, and we would tighten down those masks because there were leaks and we didn't want the air to go into the eyes and so forth. And so we started to see little red spots appear on the bridge of the nose, and then it was a little bruise on the bridge of the nose, and then we started to see some breakdown on the bridge of the nose. So the skin starts to break down and then the tissue underneath. And in some patients that breakdown would go as far as the bone. And so now we've created a huge pressure sore, which of course is an open source for infection, and that leads to other things. And even if we do have the right mask fit, even if we have everything perfectly aligned, we do have that consequence of gastric distension, and that's uncomfortable. So if our patient is NPO, it's simply a full belly of air. If our patient is not NPO, then we have the potential for gastric distension, which could then lead to vomiting. And of course, with the positive pressure going in and the vomiting coming out, we have the potential for aspiration. So we do have to be very, very careful with identifying the potential side effects of applying this particular intervention, even though there might be some benefits. So let's look at the ethical issues aligned with these particular arguments. Does it violate non-maleficence? Remember that non-maleficence is avoiding harm, right? Actively avoiding harm. So are we creating more suffering with this intervention? What is the benefit and burden balance? I would argue that we, respiratory therapists, nurses, physicians, the healthcare team, we don't need to set the benefit and burden balance. We need to facilitate that conversation with the patient and the family. What I think of as a burdensome side effect might not be burdensome to you. So having that conversation with the patient and identifying how much they're willing to accept, how much burden they're willing to accept for the benefit is very vital. But we have to evaluate that. Are we imposing more burden than benefit in this situation? And quite frankly, is it ethical to withhold a comfort measure? So no, this patient likely will not live any longer if we provide them with non-invasive ventilation. No, we will not be bridging to recovery with non-invasive ventilation. However, if I actively withhold non-invasive ventilation and I could have alleviated shortness of breath, have I violated non-maleficence? Have I continued to allow a harm to occur when I could have removed that discomfort? That's a double-edged sword because I might have provided some more burden with the device itself, but I know that this device could alleviate some of that distress. Is it beneficent? Again, what is that definition of good? The definition of good by our standards might be prolonged life, might be improved saturations, might be decreased carbon dioxide. What is the good as defined by the patient and the family? Does good mean a quiet and comfortable death? Does good mean prolonging life? Does good mean being comfortable? What is that level of good and how can we best achieve it with this intervention? So we have this concept in ethics called paternalism. And paternalism basically means that the physician makes the decision for the good of the patient. The physician knows best. He or she is very educated. They know these interventions. They know the consequences and the benefits. And so the physician says, Mr. Smith, you need to do these. And Mr. Smith says, okay, I will do what you tell me to do. That's a very paternalistic approach. It's not a collaborative shared decision-making model. So we do still have physicians in our healthcare system in the U.S. that subscribe to this paternalistic model. You should do this because I said to do it, because I know what's best. But that doesn't necessarily mean that the intervention is aligned with the patient's core values. So within this paternalistic approach, we have to offset beneficence, non-maleficence with violating that patient's autonomy. So the physician might truly believe that this intervention is the best thing to do a positive good or to avoid harm, but if the patient doesn't want this intervention, it would be violating that particular patient's autonomy. So even without the DNI or the DNAR orders, we still have to consider, is this intervention aligned with the values of the patients? Is this what he or she would have wanted? And then we have to consider futility. Futility is the concept that the intervention does not appreciably change or alter the direction of the patient's disease process. So if the patient has a terminal disease of some sort, will this intervention appreciably change the outcome of this situation? Now, futility isn't exactly a clear-cut concept. Because something might be futile doesn't necessarily mean that it wouldn't be beneficial for comfort measures. If a patient has an asthma exacerbation, we don't necessarily give that patient insulin. That would be a futile intervention if the patient has a normal blood sugar, right? So that's a fairly clear-cut concept of futility. But if the patient, like Joseph, has a terminal disease process, but this particular intervention might reduce some of his discomfort, it doesn't necessarily mean that this patient's intervention should not be considered. When we're evaluating these risks and benefits, we have to consider what side effects might be important to the patient. Is this side effect a major side effect? Perhaps if I was diagnosed with cancer and the physician tells me that I should have chemotherapy, nausea might not be a major side effect to the physician, but it might be a big deal breaker for me. That might not be a side effect or a burden I'm willing to accept for the potential impact of that particular medication. Same thing in this situation. Talking about the side effects of non-invasive ventilation, is that a burden the patient is willing to accept for the potential benefit? Does that offset itself? And how much of the burden does the patient intend to accept before declining because of that perceived benefit? And then who decides? The physician, the family, the patient. In the perfect world, we all decide together, right? We have a shared decision-making model. The physician, the respiratory therapist, the nurse, the social worker, the patient, the family, we sit down, we talk about options, we talk about the patient's values, we talk about the desired outcome and how we're going to get there. And then together as a team, we develop a plan on how to achieve our desired goals for care. And sometimes those goals for care are not curative, and we have to be very, very clear about that. So what happens when the respiratory therapist and the physician disagree? It's interesting that we have so many fabulous respiratory therapists and physicians out there with great experiences and options for care, but we also know that we're not going to agree on everything. So when do we disagree on this? An interesting study published by Seinoff et al. Looked at the attitudes of respiratory therapists and physicians about non-invasive ventilations at certain situations in the patient's quality of life span. So in the situation where the patient comes to us for care, accepts a certain level of care, but says, I don't want to have mechanical ventilation, I want to make sure I go back to my quality of life, but I'm willing to accept certain levels of care. In that situation, about 60% of physicians and 47% of respiratory therapists agree that non-invasive ventilation can provide additive effect to analgesics for the relief of dyspnea. So in those situations, those patients know that their lung disease is not getting better. They are likely not going to achieve the prior quality of life, but they're willing to accept some level of intervention. So we see that there is a disconnect. So the physicians are much more likely to utilize non-invasive ventilations. Respiratory therapists, not quite as much. And we wonder why we see these differences, but it is my opinion that the respiratory therapist sees more of the patient at the bedside, is with the patient when they experience the side effects, and the physician, through no fault of their own, simply the nature of the job, isn't there day in and day out to see how the patient reacts to the non-invasive ventilation. Now, another group of patients, those patients who are at a point where the disease is terminal, they cannot return to a prior quality of life, and we're offering non-invasive ventilation as a potential support. 42% of physicians and 32% of respiratory therapists feel that it's appropriate to offer this intervention. So again, we're seeing a difference here, mainly because respiratory therapists have more of that one-on-one interaction with the patient, watching them as they near the end of life and how this machine interacts with their disease process. So a new question: should physicians add non-invasive to the do not attempt resuscitation or do not intubate discussion? Or, in other words, offer it as another option at end of life? And so here we see new data about the perceptions of respiratory therapists versus the physician. So 62% of physicians indicated that non-invasive ventilation should be included in these discussions at end of life. 87% of respiratory therapists feel this should be included. Why do you think we have such a huge number of respiratory therapists wanting this intervention discussed? Probably because we've been there at the bedside when we have that vague notion of, well, non-invasive could be helpful. Well, nobody asked the family, nobody asked the patient before he lost decisional capacity. So the respiratory therapist has that experience of being in that very difficult situation of, I don't know what the patient would want at this time. If we had this discussion with the patient when we discussed end-of-life options, it would take a lot of the question mark out of whether or not we should be able to use this at that point in time. Now, in reality, about 20% of physicians actually have this conversation at end of life with the option of non-invasive ventilation, and less than 10% offer non-invasive ventilation as an option when we have comfort measures only. So again, respiratory therapists feel strongly that this is an intervention that should be discussed more frequently in these situations. So here are some general recommendations on how we, as respiratory therapists, can interact with our families and with our physicians and our nursing colleagues and our social work colleagues to help transition this discussion. First, talk with the family. Clearly explain that advanced directive status. In addition to making sure that we reduce medical jargon, we also need to reduce the legal jargon. I don't know about you, I'm not a lawyer, I'm not good at this. This is where our social workers can come in and help us understand the limitations and the capabilities of that advanced directive, what we can and cannot do, and the consequences so that the family understands where we can go with this particular directive. Clearly explain the benefits and risks of whatever the proposed intervention might be. That includes all of the contraindications, all of the side effects. You know, if you think that the family might need to know that the straps can be uncomfortable on a non-invasive mask, clearly explain that the straps can be abrasive. It can be a little tight. The back of the neck might hurt. Sometimes patients need to have some lotion or some powder on the back of the neck so that it doesn't abrade the skin on the back. So even though that seems like a very minute piece, explain all the side effects and contraindications so that the family doesn't come back later and say, boy, if I had known that this was a side effect, I'd have never signed off on this. I would have never approved this for my loved one. Informed consent, and I can't stress this enough, informed consent is a process. Informed consent is not a one-time option. It's not a signed piece of paper. Rather, it is a process to make sure that the family and the patient understand as much of what we're proposing as possible. And if things change, they need to be updated. The patients and the families need to be able to make these decisions with the best information available, and they need to be able to withhold that consent if this violates any of their personal belief systems. We need to clearly communicate goals of care. Is this curative therapy? Is this palliation? What desired outcome do we expect from this intervention? What outcome do we expect from this hospitalization? We need to be very clear with the families and the patients so that they're not surprised when we have a negative outcome. We also need to make sure we remind the families that just because a patient might respond to non-invasive ventilation, that acute disease process doesn't necessarily mean that the chronic disease process has been reversed. And then again, communicate that expected outcome. Where are we going with this? What do we expect to happen? Is this a positive outcome? Is it a negative outcome? And help coach the family toward that end. Something that's very important to consider is that some of us view mechanical ventilation as a treatment. Mechanical ventilation, non-invasive ventilation, doesn't actually fix anything. It simply buys us some time. It helps the body oxygenate. It helps the body ventilate. It helps the patient relax a little and take some of the burden off of the patient's lungs so that perhaps the original insult can be resolved. It's not going to fix anything. Many times mechanical ventilation actually causes more problems, but it's very important that we understand that this isn't a therapy that we're going to make something happen with, but rather buy us some time until we come to whatever outcome that might be, whether that's resolving the initial insult, bridging to recovery, or simply providing comfort measures during the time that the patient is at end of life. Let's go back to Joseph's situation. So if you'll recall, we've got this acute respiratory failure caused by a pneumonia on top of the chronic kidney disease. Remember, his kidney function is 0. The kidneys are not going to get better. The parents are not going to transplant Joseph with his kidneys. So we have an acute process that we could use, non-invasive, to improve that comfort level, to bridge to a point in time when the pneumonia is resolved, but we're not going to be able to bridge Joseph to recovery from the kidney disease. So we have to keep those two things separate. So the question is it ethical for Joseph to receive non-invasive ventilation at this point in time? If we look at this as a comfort measures only, as an alleviation of that acute respiratory process, then yes, we can use non-invasive ventilation without violating beneficence, without violating non-maleficence, and without violating the patient's autonomy, because even though we have a D&I order, we're not providing endotracheal intubation with this particular intervention. So the story of Joseph was, again, as I said at the beginning, one of the first ethical dilemmas I faced in my career. Unfortunately, this was not as clean of a case as I've presented here. Joseph did have non-invasive ventilation while he was in our facility. Unfortunately, again, many years ago, this was at a time when those masks were not that flexible, they were not that comfortable, and they were not that cushioned on our patient's nose. So the nasal mask we used at the time was a lot of hard plastic, and it was not very comfortable, and it didn't fit his face very well. So we had to use the straps relatively snugly to make sure that it would fit onto Joseph's face. And unfortunately, he developed a lot of breakdown on the bridge of his nose. We did have breakdown all the way to the bone, and then the respiratory therapists were very upset with the continuation of the non-invasive. At that point in time, we had to reevaluate the burdens and the benefits. And the respiratory therapy team was very much opposed to placing non-invasive ventilation back on Joseph at that time due to the added burdens we had imposed with that intervention. So even though it was ethical to provide Joseph with the non-invasive at the time he was admitted, over time we reevaluated, identified extra burdens, talked with the physician team, talked with the social workers, talked with the family, talked with the administration, and then discontinued non-invasive ventilation for Joseph due to those added burdens. So we also have to remember that as we move through these situations, once a decision is made, we're not done with the case. We continue to reevaluate and take in new information and then make ethical decisions based on that new information. Here are the references that I used for this presentation, just in case you're interested in reading more about this phenomenon. Thank you very much for joining me, and have a great day.